It's wonderful to be here. I appreciate you all taking time out of your very busy schedules. I know this has been an overwhelming week for you, trying to fit in all your other meetings and classes and workshops, etc. So I'm very grateful to have you here. I'm going to kind of tell a story today and intertwine a discussion of research with it. And I've got too much information, of course, so some of the slides I'll click over fairly quickly, but this particular work came out of an experience about 2 years ago when my sister-in-law was dying of ovarian cancer. I had written about and studied death and dying issues for a number of years before that. As a matter of fact, I was writing, I think I told Leanne this already, I was writing my first article on death and dying when my dad died. I was pregnant with my oldest, now almost 28, and my dad died suddenly of a heart attack. So I pushed that article away for a while. Couldn't come back to it for a couple of months, and then the next time I was writing one on death and dying, I said to my mom, "You be careful. You know, behave yourself. Don't take any chances." And fortunately, she didn't die during that article. But I've had an interest in death and dying issues for a long time. Maybe it's something that many of us come to naturally as we get older and confront these kinds of experiences. So after a number of years of writing about and studying some death and dying issues, I then found myself in a situation with great applicability of all of these things that I've been writing about. And let's see. I've got it backwards. Maybe that won't work.
Yes, it's working.
Very good, very good. So I was already divorced from my former husband at the time that his twin sister was diagnosed with ovarian cancer, but I'd kept very close to the family. Indeed, I was probably closer to them than he was. And so I was able to spend time with them. I live in Dayton, Ohio. They're in Cleveland, which is just about 4 hours away, so it's a very close trip. So after Annie's diagnosis of ovarian cancer, I was still spending a lot of time with them. And one of the things that I was struck by very early, and of course I read about this in the research and come across it in my own research before, was their lack of willingness to talk about death, potential terminality, etc. At the very beginning, that's much more common, much more understandable, and it's very culturally driven. So one of the things I hope we can all talk about are some of the cultural differences that you've come across in regard to individual, family, doctor willingness to talk about impending terminality. Ovarian cancer has a very high rate of death associated with it. So from the time that we knew she was diagnosed, I assume everyone knew that the odds did not look good. My other sister-in-law, whose name is Mary, is one I thought would be especially aware of these issues. She's a nurse, a master's degree, a nurse practitioner from Case Western Reserve. She's really the person in charge of all the caregiving issues in the family. And from the very beginning, Annie was discouraged from looking up information about her illness online. Was discouraged by Mary. "No, I don't want you to read about this." Mary's concern from the very beginning was something that shows up in a lot of the research, the role of hope in the process of dealing with any kind of health problem, certainly, but especially one that is frequently terminal. and she had read some of the work, not the same kind of academic work, and empirically based studies, etc. That we would. More things written by doctors. Jerome Grutman, for instance, is one who's written quite a bit on this. And Mary was convinced that nothing should be said, not even your tone of voice, should convey any concern to Annie, because it would take away her hope. So that was always Mary's emphasis. So people like me, whose voices were going to express concern, but how you doing, honey, etc. That expresses concern. Now, I didn't know how else to talk to Annie at this time. I didn't feel that it was appropriate to say, "Hey, so Annie, how you doing? Everything good? Oh, good. Glad to hear it." But that's how Mary wanted people to talk to Annie. So the focus was that Annie should hear only encouragement. Now, within Western cultures, there's much denial of death, much denial of impending terminality. I understand already from talking to some of you, your awareness of the cultural differences and how it is handled differently in different places. Anybody here from Japan? Is there much of a relationship between Singapore and Japan? Yeah.
A negative relation.
Okay. I understand. Having spent time in China, I've experienced that as well, that negative relations with Japan. Anyway, there's been probably more research on people's unwillingness to talk about death in Japan than there has been in any other Asian country that I've come across. So in Japan, doctors don't tell you when you're dying. Well, in the U.S., that used to be the case, but ever since Elizabeth Kubler-Ross's writing starting in the 60s, our awareness of the problems associated with denial of impending terminality has been raised, and I thought most well-educated people were aware of that. I certainly thought that my sister-in-law Mary, as a nurse, having worked as a nurse for, I don't know, probably close to 30 years at that point, dealt with all these healthcare issues, would be well aware of the fact that we can't deny terminality, and that's not fair to patients. As a health communication person, this was something that I thought was kind of obvious. Boy, was I wrong. So it was quite a learning experience for me. So in Western societies, then there's much denial of death, much more with all the modern technology to prolong life and how much longer people are living. Whereas most people used to die at home, surrounded by loved ones. That's very rare now. Most people, even those who do not want to die in the hospital, do die in the hospital in most Western cultures. So I thought it was a very big issue. The denial of death was a huge issue in my ex-husband's family. Everybody in this family, except not my mother-in-law, who just kind of goes through life in la-la land. Just, everything's fine. She's such a sweetheart, but doesn't confront things because she's kind of in la-la land. Is that a metaphor that makes sense to you? Good. But everybody else in this family has a very strong need for control. And of course, that general predisposition, a need for control, would be applicable in this kind of situation. Annie's affairs, the term that is so often used. I'm not quite sure what affairs are. Well, in this context, anyway, we're not in order. No one knew where her various papers were. No one had permission to pay her bills. write checks from her account. There was no preparation for death, even when we were obviously within maybe a month and a half. The doctors had not given any specific timeline, but anyone spending time with Annie would know that we were very close to time of death. Thus, there was also no opportunity to discuss feelings for each other, to conclude relationships. Now, in the primary part of the family, it's because the three women, my mother-in-law and two sisters were the key to the family. My father-in-law had already passed away, and my ex-husband was not as closely connected to the family. But with Mary, Annie, and Nana, there wasn't much need for suddenly telling each other how they felt. In many families, there are. But there had always been great love shared here. My ex-husband and his twin probably had some issues that they could have resolved. They had never been as close, and an opportunity to realize, okay, Annie's approaching end of life. Are there some things you want to talk about? There would have been very appropriate in that situation. Never happened. Historically, we've seen two different cultural approaches to death. Ars moriendi, I think these go back to the Latin. I've read about them mostly in Italian literature, a good death, or ars vivendi, a good life. Now, in historical writings, these are interconnected. A good life culminates in a good death. A good death is part of a good life. But in many cultures, we don't really recognize that relationship. So, distinction that we find in much of the discussion of this between those who want to maximize the quality of their remaining life versus those who want to keep on fighting for life. Do you see that in Singapore? That tendency that we certainly see it in the U.S. Even though someone is in a very advanced stage of illness, there's a tendency to keep on trying chemotherapy and radiation and various and surgical treatments that will not improve quality of life. Might prolong life a bit, but will not improve quality of life. And of course, we've got the notion of the fact, according to the research, that generally continuing treatment typically lowers one's quality of life when one's terminally ill. Okay, so before we move on to talk more about this notion of hope, because after Annie's death and seeing the negative impact of this whole experience on my relationship with Mary is still not recovered from this time and from the different views that we had about communication at end of life. So I spent a lot of time immersing myself in the hope literature, interesting body of literature. What do we know then about family and patient information preferences at end of life? We know quite a bit. One interesting systematic review of 27 studies found that patients and caregivers mostly prefer honest and accurate information. And as I say these things, I will ask you to keep in mind how some of the later research will show that while they say they prefer these things, actions are not always consistent with that. They want to be provided with empathy and understanding. Only a minority of patients and caregivers claim that they desire to avoid detailed information just to preserve hope, but most families try to control the information that comes to the patient, and many caregivers try to control the information that comes to the patients, even though patients claim they don't want to avoid that detailed information, although there's some problems with that literature. So the majority of patients and their caregivers report that they want the health provider to be honest when discussing prognosis and end-of-life issues. But there are different views of what constitutes an honest approach. As we first think about this, it kind of seems straightforward. Well, tell you what's going on. But it's obviously not that simple. Some people desire a straightforward or direct approach. That's what I'm pretty sure I would want in this situation, but I've never actually been in that situation. If I were, if tomorrow the doctor told me, ooh, you've got pancreatic cancer, for instance. I'm just guessing at how I would react. And that's true for all of us until we go through this kind of situation. I'm sure that all of us can think of past situations that we've encountered where we thought, oh, if I was ever in this situation, this is how I react. And then when it actually happens, yeah, not so much. I would find myself handling it differently. Anyway, so some prefer a straightforward or direct approach. Others desire an accurate information, but without bluntness or without too much hard, factual, or detailed information. And it's hard to know, of course, who wants what, unless you know this individual very well. So if I were telling my mother, someone with whom I've had many and detailed discussions about our end-of-life wishes, I think that adapting to her would be very easy. Had I been communicating with my dad before he died, it wouldn't have been as straightforward. My dad was in major denial. He'd had heart problems, died suddenly of a heart attack. I've told some of you this story already. For him, denial was a very real issue. The day he died, he was sitting on the end of the emergency room table, and my sister came in and she heard him saying the word hiatal hernia. He'd never been diagnosed with a hiatal hernia. No doctor had ever told him that, but he had blamed the heart pains that he had been having for quite some time then on this alleged hiatal hernia, self-diagnosed, really because of his denial. There. And then still other people, besides the first two types that I've mentioned, desiring a combination of both honesty and optimism. Not always an easy balance to achieve. Several of important studies then have emphasized the importance of not giving people unrealistic hope or not colluding with people's unrealistic expectations. We'll come across some data up here a little bit later that shows our willingness to have unrealistic expectations in certain situations. And the data also show that many patients find their situation more frightening if they sense that even their doctors can't face the truth. That's something scary, isn't it? As I'm dealing with this situation that we all should know, it's very natural, very normal. Every one of us is going to die. It is possible, though, for people to cope with their illness by wishing for a cure, usually put as hoping for the best, while at the same time acknowledging the terminal nature for their illness. Preparing for the worst is the terminology that's usually sold. Hoping for the best while preparing for the worst. That's part of that delicate balance then that the title referred to. One interesting two-phase study I came across a couple of years ago of terminally ill cancer patients, and of course a lot of this research looks at cancer patients. Found the following ratings of important concern. Top was having a sense of hope. Hope is indeed important to people. They want to know what symptoms they might experience to help decrease some of that uncertainty. And then they want to know their prognosis, and they want to be able to talk to their doctor truthfully about their prognosis. Again, this balance, wanting that sense of hope, and all of these other things is not at all easy to achieve. So, why the concern about hope? Let's talk a little bit about what we know then about hope and the role that it plays in health care. As you can imagine, with a concept like hope, there are a lot of different definitions that come up in the literature. A positive expectation with an unclear outcome could result in hopeful feelings. That's one quote that's used a lot in the literature. Combination of honesty with sensitivity and empathy was identified as hope-giving in several of the studies I came across, and an awareness of the difference between hope and wishing. Hope is usually conceived as grounded more in reality, whereas wishing is about fairy tales. Do you wish upon a star? Here every single night. First time when I go out and it's dark, I look for the first star and go, starlight, star bright, first star I see it at night. And the wishes, of course, the last several years have all been about my son. Making it through school and, doing all right on this physics test, and now it's the job. Mark, I just found out last night his best friend got a job. He's moving to Lexington, Kentucky. My son's still struggling away at, so those are wishes. Then I hope they'll come true, but a difference. Of course, another commonly used definition, a multidimensional dynamic life force characterized by a confident yet uncertain expectation of achieving a future good which, to the hoping person, is realistically possible and personally significant. Interesting, kind of difficult to operationalize, right? But interesting. So there are a bunch of models of hope that have been developed, and very few people have been successful at measuring it or labeling it as true or false. It's suggested to researchers that they focus on things like the meaning of hope to the individual. And we'll go on to talk about some of the different things that one can hope for. We use the word hope like it's a specific concept. And we really, in the English language, have only one word for hope. I've often wondered if other languages, and some of you could probably contribute about this, have different words for some of the different kinds of hope that we'll talk about in the middle. In a minute. So patients are generally less concerned than physicians about damaged hope. Physicians worry about damaging the hope of their patients, and that balancing hope with honesty is an important and difficult skill for health professionals. The whole area of bad news delivery is a big one within our field, and the role of hope is important within that. Patients do need a realistic sense of the future so that they will do what they need to do in their remaining time. You may have thought at some point, if I were told that I'm going to die in 6 months, how would I change my life right now? Probably quit your job, right? Wouldn't most of us quit our, not Mohan. Mohan never. The rest of us would probably quit our jobs. I don't know. Well, I'm going to have to think about that. Let me know.
Cancel all the holidays at the patient.
Yes.
Focus on work.
That's it. Oh, I got several more contributions to make before I die.
He's not the only one. He's definitely not the only one here.
Okay, well that's good to know. That's good to know. And I do wonder what I would do. So I'd say, quit my job. We'll see maybe someday. There are advantages to knowing. in some way ahead of time. Oh, I'm going to die, and most of us will be in that situation. Lingering deaths are more common in today's world than sudden death. So in many ways, my dad was very lucky. He was only 58, never got to see his grandkids. That's not so lucky, but he would not have handled a lingering death. Well, my father-in-law, the same thing. They both went very suddenly. Then you don't make those decisions. But for many of us, lingering death, there's probably a better word than lingering, but I hope you understand what I mean. There are decisions then that need to be made, and an opportunity to, in some cases, reconcile relationships. I think, for instance, my mother and my sister would have a lot of issues to reconcile if or when it's known that one of them is going to die. I don't know if it would actually happen. They don't have a very good relationship, and you may have some family members that way. I hope you don't. But I do. The argument is made, of course, that we need hope so that we will not simply give up on life. We also know that end-of-life decision-making is facilitated by trying to express things clearly, avoiding euphemisms, being clear about goals and expectations of treatment. This is what we can expect this treatment to do, using the straightforward words rather than euphemism then, such as death or dying, while also helping to maintain hope, and frequently in some ways that go beyond just hope for unending life. I don't know if any of us would really hope for that. What do you think? Would you hope for unending life? After a while, we get tired. I tell you, I'm to that point where there's sometimes I say, okay, God, yeah, you can go ahead and take me now. I'm so tired. It alternates between that and wanting to just crawl in a cave somewhere and hide from other people. Does that ever sound appealing to you? Anyway, that's like talked about statistics, and we don't use statistics as much at end of life now because we found that they're so unreliable. But they do generally rob people of hope, the argument is made. Again, something very difficult to investigate empirically. Several advanced cancer patients in one study saw statistics as potentially hope-destroying, preferred instead to hear good news stories. And patients who were more aware of their situation were more likely to report that they were losing hope. Now, that's not always bad. You know, losing hope means acceptance of what is going to happen. And I think that's a good thing, and associated with a better life. However, there is some research that shows that hope can be useful in helping us cope with illness. That hopelessness is associated with depression, suicidal ideation, a desire for hastened death, and decreased physical health. So important issues. Facilitating a sense of optimism in research has identified the important role of a sense of optimism in facilitating treatment, enabling treatment to work, and maintaining positive attitude amongst patients. Even unrealistic optimism sometimes helps serve as a resource for patients. The issue for me always comes back down to how much do I want to deny what's going to happen versus how much do I want to be open and accepting of what's going to happen. Hopeful patients do follow treatment recommendations more, something that we know is a big deal in health literature. They tolerate discomfort more actively involved in their self-care, and have higher levels of psychosocial adjustment. So a little bit here about some strategies to think about that we know from the research are useful when discussing statistics, but again, we don't cite statistics to patients much more because we know that we're so frequently wrong about those. However, focusing on immediate milestones and hurdles is something that's rather productive. Emphasizing positive and achievable treatment goals. Making it to my daughter's wedding, for instance. Can I make it to my daughter's wedding? Can I make it to my son's graduation? So no, my daughter's married and my son's graduated, so I made it to those. But those are hypothetical examples of the kinds of things that the research takes a look at. These things also soften the impact by vaguely suggesting or recommending the discontinuation of treatment, but giving the patient the choice, and we know the role of patient choice and control in healthcare. Very, very important. So, perceiving some form of hope is central to this. And many argue that it's central to this, even if it means that the doctor withholds some central information in order to maintain a positive attitude. So many healthcare providers say that they respect denial, that you can't make someone hear what they do not want to hear. I was sharing with Leanne recently a story about a colleague of mine whose father had cancer, was in the Mayo Clinic. As she told me what the doctors were saying, it was obvious that he was dying. And my data just came from her based on what the doctors said, and she was talking to me about how she wanted to translate this experience that she was going through into something useful, productive, an article that she could write. I said, oh boy, based on the things that you've been telling me, an article about the rhetoric of terminality would be really interesting. And she said, yeah, the rhetoric of survival, that would be interesting. I said terminality, she thought survival. So some doctors say, why not allow them this hope and let the patient come to terms with their limited life expectancy at their own pace. So one study, 56 terminally ill patients, said that they wanted their physician to be honest, but 91% of them also wanted their physician to be optimistic, and the most highly ranked factors were those that instilled a sense of being able to fight the cancer. Now, healthcare providers try to preserve and can preserve hope more realistically by being honest, acknowledging the difficulties in giving prognostic estimates, etc., presenting information about palliative care at a rate that the patient can assimilate, and respecting alternative treatments, something I think that is recognized a bit more in Asian countries than it is in most Western countries. These are the things that the research, I think, most interestingly, identifies as hope-giving, saying that the pain will be controlled. You have cancer, you know you're going to be in a lot of pain at the end of life. So a palliative care specialist assuring me the pain will be controlled. That's going to give me hope. The healthcare providers who appeared very knowledgeable about the patient's situation, offering to answer all of the patient's questions, saying that each day the patient survives, new developments are possible. And we know that to a certain degree that's true. Every day there is more research going on. Some of you may have come across the interesting research on using various viruses to treat cancer, including measles, the HIV virus. There's been success at numerous institutions at using those kinds of viruses to treat cancer. Talk about an interesting and unexpected development, and noting that the patient's will to live will affect the outcome. Haggerty 205 a study, 2005 a study, should properly say, was one that I found rather interesting. Most patients perceive that the provision of realistic information in a supportive, collaborative environment was more hope-nurturing than avoidant behavior. Other research by Allison, did she change her name? She got married just a couple of months ago. I think Scott, she's still publishing under Allison Scott, University of Illinois, a PhD, now teaching at the University of Kentucky. She did some fascinating research on families' tendencies towards open discussion and generally found that those families who avoided discussion of terminality were ultimately, I know I already used that word, ultimately more hopeless, felt more hopeless than did those that openly talked about the potential realities of what could happen. Hoping to get to a statistic that compares the expectations, what doctors say versus what patients hear. And since I'm not going over all this, I'd be happy to share this with any of you with special interests in the topic. How the messages are communicated with communication that's more warm versus communication that's more cold. And we know healthcare providers differ drastically in this regard. That affects hope. I can say the same thing, but if I say it with warmth and compassion is something else that will come up in the literature, it makes a difference in the impact on patients. That certainly doesn't surprise us. That's what we study, right? Communication. But there's a spectrum of hope. Some hope is just maintained by healthcare providers being there. I know you will be there for me until the end, treating the patient as a whole person who's entitled to know what will happen at end of life. So, hope's best engendered by combination of honesty and empathy, framing hope in a wider context. Hope in relationships, in beliefs and faith, in having one's symptoms controlled, in maintaining dignity. That's a terrible thought as we approach end of life, isn't it? The loss of dignity as a result of incontinence and those other outcomes. Yeah, so that kind of assurance is helpful. Finding inner peace, enjoying a sense of humor, thinking about meaningful events in one's life. So there are different types of hope. Then hope of being cured, hope of living as normally as possible, presence of confirming relationships, a reconciliation of life and death. Again, that death is a part of life. And an awareness that hope for a cure may frequently be misguided in the context of a terminal illness. So these are some of the kinds of things that patients who seem to cope well hope for, maybe making it to those certain events that I talked about, finding meaning in their own life and worth, etc. Peaceful death, that would be nice. Wouldn't it? Don't we all want a peaceful death? Hope in the healing of relationships, special times with family and friends, spiritual meaning. As I referred to before, does the use of the word hope for all of these different things cause confusion? And it certainly does in the research. We focusing on a cure and continued life expectancy is just one way of thinking about hope. So thus one asks, are these all hope? Or are these positivity in some other form? Calling them all the same thing. Is that a problem? And when we say what we say we want is not necessarily what at end of life we really want. So compassion, along with the truth, doesn't mean that patients really want the full truth. Adaptation then, as we know with all communication, to the individual is important. The role of compassion, I think I've already referred to in as communication as scholars, and as we think about words, we notice several things. And then compassion doesn't always mean a compassion. It frequently meant not telling patients things that they weren't yet ready to hear. Now, that's not what I think of as compassion, but that was how compassion was enacted in the lived experiences of many of these patients, that hope doesn't always mean hope, truth doesn't always mean full truth. Of course, we're well aware of the dialectical tensions in all relational issues. So, as a health communication scholar, then, this was my fundamental bind, dealing with Mary and Annie. If Annie asked me something, like when Mary wasn't there, about why did the doctor say such and such? Why did the doctor ask me if I really did not want it's end-of-life documents, it's etc. Why did he ask me that? And I would try to answer that. I'd get tattled on by Mary's friends who were there, who, as soon as they would leave, they would call, oh, you can't believe what Terry just said to Annie. She actually told her that, well, the doctor would be wondering why, so it was an interesting bind then for a health person, and of course, Mary sincerely believed she was doing absolutely the best thing for Annie. And Annie didn't really accept her impending death until just within hours of the time that she died. So her affairs were still not in order. No one knew where her bank book, checking accounts, bills were, etc. Patients pick up on, especially from care providers, but also from family members, what's really going on, and feel disconfirmed. Well, why won't anybody tell me what's really going on there? So we're not idiots. There we pick up on things. So a lot more problems are caused by denial, more suffering, more anguish, and we do know that the family, like Mary, is typically more likely to deny than are most patients. There's great difference in prognosis between what the physician thinks and what the patient thinks. Physicians overestimate the amount of information that they've given to patients, and they overestimate the amount of knowledge patients have about their illness. Surrogate decision makers tend to be especially low in the accuracy of their predictions that they make about what the patient would want at end of life, because they haven't talked about this. Here's the statistic that I was looking for. So, amongst candidates for breast cancer adjuvant therapy, 70% of patients overestimated their chance of cure by 20% or more compared to what their physician thought their chance of cure was. Great example of overestimation. Among other patients with cancer, 2/3 had a poor prognosis. Only 21% perceived that they had a poor prognosis. But patients do feel that knowledge is empowering. You know, as a patient, that's what I want. I feel that I should be involved in the decisions that are made, and I need knowledge to do that. We do have more control over our life when we have full information. We got a little bit more here about patients' views. Key factor is so that patients' preferences can be followed. So I've already talked more than I should. I'm going to hope that we can all, as a group, talk a little bit more about this issue. Your thoughts, your experiences, your perceptions. I saw some head nods, for instance, when I talked about different words for different kinds of folk in different cultures. As you think about these kinds of issues, what comes to mind? Well,
Thank you
I
so
thank you
much.
very much. Gosh, I've enjoyed this discussion. My whole time here with you, it has just been a real blessing for me. Thank you.
Thank you so much.